Hello everyone, myself Dr. Jill Choksi, lecturer in Physiotherapy Department at UN Mehta Institute of Cardiology and Research Center. Today our topic is about the respiratory muscle testing. As we are all know the muscles that help in inspiration and expiration process, but how to evaluate and interpret these respiratory muscles that we are going to learn in today's lecture. So, before going to the testing, we just overview the kinematics and the muscles that are responsible for the ribcage movement. So, the content of the today topic would be kinematics of the ribs and manubriosternum, muscles associated with the ribcage, antagonism and synergism of the diaphragm and the abdominal muscles, the need of the respiratory muscle testing, why it is important to assess these respiratory muscles, and the evaluation of respiratory muscle strength and endurance. Now we'll start with the kinematics of the ribs and manubriosternum, as the movement of the whole rib cage is depending upon the types and angle of the articulations, movement of the manubriosternum and the contribution of elasticity of the costal cartilage. As the axis of rotation for the each rib is slightly different due to their different length, shape and the downward angle of each ribs. So the axis of rotation for the upper ribs that is lie close to the frontal plane, which allows the motion of those rib in the sagittal plane, and the axis of rotation for the lower rib that lies close to the sagittal plane that allow the motion of those rib in the frontal plane. Frontal plane that divides the body into front and back portion, and the sagittal plane that divide the body into right and left side. As you can see in this figure, for the upper ribs, the axis that lies close to the frontal plane, and for the lower rib, the axis that is lies close to the sagittal plane. So now, pump handle motion. Why it is known as the pump handle motions? Because as the during inspirations, most of the movement occur at the anterior aspect of the upper ribs. These upper ribs pushes the sternum ventrally and superiorly and increasing the anterior and anteroposterior diameter of the thorax. As you can see in this figure, during inspirations, the upper ribs pushes the sternum ventrally and superiorly and increasing the anteroposterior diameter of the thorax. Same as the pump handle motion, this combined rib and sternal motion occur in the sagittal plane. That is why it is known as the pump handle motion of the thorax. And the bucket handle motions, why it is known as the bucket handle motions? Because as the lower ribs have more angle shape and it has indirect attachment anteriorly to the sternum. These factors allows more motion at the lateral aspect of the rib cage. And so the elevation of these ribs increasing the transverse diameter of the thorax. Same as the bucket handle motion, this motion occur in the frontal plane. That is why it is known as the bucket handle motion of the thorax. Muscles associated with the rib cage movement. So the ventilatory muscles are the striated skeletal muscles that differ from the other skeletal muscles in a number of ways. Striated skeletal muscles are the voluntary muscles, which means that we can control its function actively. And this striated skeletal muscle primary function is to produce force and contract to support the respiration as well as the posture and the locomotion. These striated ventilatory muscles differ from the other skeletal muscles in a number of ways. First is the increased fatigue resistance and greater oxidative capacity. Means these muscles are not easily fatigued and it have a greater oxidative capacity. Second one is it contract rhythmically throughout the life. It works primarily against the elastic properties of the lungs and airway resistance rather than against the gravitational force. Fourth one is the neurological control of this muscle is both voluntary and involuntary. Voluntary means we can control its function, and involuntary function means it perform automatically. We cannot control its function and it is a life-saving. Primary muscles of ventilation. For the quiet ventilation, these include the diaphragm, intercostal muscles and the scalene muscles. These all muscles act on the rib cage to promote inspiration. Let's see one by one how this muscle helps in inspiration. There are no primary muscles for expiration because expiration at rest is the passive process. The first one is the diaphragm. It is the primary muscle of ventilation. It is divided into two portions, crural fiber and the costal fiber. This fiber travels superiorly to insert it into the central tendon. This portion is known as the zone of opposition. It is a vertical fiber of the diaphragm that lies close to the inner wall of the lower rib cage. So during the tidal breathing means inhaling and exhaling while you are relaxing. So during the tidal breathing, this fiber of the zone of the opposition of diaphragm contract, which cause the dome of the diaphragm to descend and increase the intra-abdominal pressure. With deeper breathing, the abdomen now compresses further and act to stabilize the central tendon of the diaphragm. With continued contraction of the costal fiber of diaphragm against the central tendon that is stabilized by the abdominal pressure, the lower ribs are now lifted and rotated outwardly and increasing the transverse diameter of the thorax. This is all about the diaphragm. Now coming to the intercostal muscles and the scaleni muscles. In the posterior view of the thorax and vertebral column represent the three muscles. First one is the levator costae. It goes from the tip of the transverse process to the superior border of the rib below. It acts by elevating the ribs. The second one is the external intercostal muscles. It goes obliquely superiorly and medially. And together with the levator costae, this muscle act as the inspiratory muscles. And the third one is the internal intercostal muscles. It goes obliquely superiorly and laterally, and this depresses the rib. So it is an expiratory muscles. Scaleni muscle. Scaleni muscles are also primary muscle of quiet ventilation. They lift the sternum and the first two ribs as it is inserted into the first two ribs, and increase the upper rib movement in the pump handle motion. These scaleni muscles also function as the stabilizer of the rib cage. The second one is the accessory muscle of the ventilation. This muscle assists with the inspiration or expiration in the situation of stress such as increased activity or during the disease. The accessory muscle of inspiration like the sternocleidomastoid, pectoralis major, minor and the subclavius increase the thoracic diameter by moving the rib cage upward and outward. The abdominal muscles are the expiratory muscles as well as trunk flexors and rotators. The major function of these abdominal muscles with regard to ventilation is to assist with the forced expiration. Antagonism and synergism of the diaphragm and the abdominal muscles. Before moving forward to this topic, we have to understand the basic terminology of agonist, antagonist and synergistic. Agonist muscle means a muscle that initiate the movement. Antagonistic means muscle that oppose the action of the another muscles, and the synergistic means muscle that support the agonist muscles. It is not the main muscle of the action, but it just support the agonist muscles. These diaphragm and the abdominal muscles antagonistic and synergistic at the same time, but in practice they cannot function independently. During inspiration, contraction of the diaphragm lowers the central tendon that will increase the vertical diameter of the thorax. As you can see in this figure, during inspiration, contraction of the diaphragm lowers the central tendon of the diaphragm that increase the vertical diameter of the thorax. This change is opposed by the stretching of the mediastinal content and the resistance of the abdominal viscera, which are held in place by the abdominal girdle that is formed by the powerful abdominal muscles like the external oblique, internal oblique and the transverse abdominis. Without these abdominal muscles, the abdominal content displays anteriorly and inferiorly, and the central tendon would not be stabilized to allow the diaphragm to elevate the lower ribs. This antagonistic and synergistic action of the abdominal muscle therefore is essential for the efficiency of diaphragm. During expiration, the diaphragm relaxes and the contraction of the abdominal muscles lowers the thoracic floor. which will decrease simultaneously the transverse and anteroposterior diameter of the thorax. As we learned in previously, during inspiration, most of the movement occur at the anterior aspect of the upper rib cage. Okay, so this pushes the sternum ventrally and superiorly and increasing the anteroposterior diameter of the thorax. With continued contraction of the diaphragm against the central tendon, these elevate the lower ribs and rotate it outwardly and increasing the transverse diameter of the thorax. But during expiration, the diaphragm muscle relax and decreasing simultaneously both the transverse and anteroposterior diameter of the thorax. Increasing the intra-abdominal pressure push the viscera upward and raise the central tendon of the diaphragm. And this will decrease the vertical diameter of the thorax and close the costodiaphragmatic recess. Therefore, the abdominal muscles are the perfect antagonist of the diaphragm as they reduce simultaneously the 3 diameter of the thorax. As you can see in this figure, during the time of inspirations, tone of the diaphragm is more. At the time of expiration, the tone of the abdominal muscles are more. Need of the respiratory muscle testing. The capacity of the respiratory muscle pump is vital for the movement of air to the level of gas exchange in the respiratory system. The impairment of respiratory muscle pump compromises the ventilation, gas exchange and tissue respiration. In conditions, for example, chronic obstructive pulmonary disease, congestive heart failure, where load on the respiratory muscle is increased or the capacity of respiratory muscle is decreased, muscle fatigue can occur. The respiratory muscle weakness increases the relative load for the breathing. This can lead to consequences like the dyspnea, impaired exercise performance, ineffective coughing, and the respiratory insufficiency. So, the respiratory muscle strength testing, it is divided into 2 parts. First one is the volitional test and the non-volitional test. In the volitional test, there are maximum inspiratory pressure. Second one is the maximum expiratory pressure, sniff nasal inspiratory pressure, pick cough flow, and the last one is the inspiratory mouth pressure. And in the non-volitional test, there are first electrical and magnetic phrenic nerve stimulation. Second one is the diaphragm ultrasound. Third is the electromyography. Fourth one is the electroencephalography. Fifth one is the optoelectronic plethysmography. And last one is the transdiaphragmatic pressure. We will see volitional test one by one. First one is the volitional test, in that maximum inspiratory pressure. It is also known as the MIP. It reflects the strength of the diaphragm and other inspiratory muscles like the sternocleidomastoid. It is determined by measuring the upper airway pressure, mouth for the outpatients and the trachea for the intubated or tracheostomized patient during the maximal voluntary inspiratory effort. It is measured at the residual volume to record the maximum value. Residual volume means the air that remains in the lung after forceful expiration. For performing this maneuver, patient is in a sitting position with or without using of the nose clip. You have to instruct the patient to take a few tidal breaths through the mouthpiece or mask and then exhale slowly and completely to the residual volume. Then you have to instruct the patient to breathe in as hard as possible and maintain the inspiratory effort for at least 1.5 seconds. The largest negative pressure that is sustained for at least 1 second should be recorded. Allow the patient to rest for 1 minute and repeat the maneuver 5 times. Variability among the maximum value measurement to be less than 10 cm H2O. The difference should not be more than 10 cm H2O with each attempt. This figure shows the subject performing PI max and PE max maneuver. So the figure B for the PI max, x-axis shows the time in second and the y-axis shows the pressure. This is the peak pressure. This is the pressure that is attained maximum during the inspiratory effort, and this is the PI max, that the average pressure that is sustained for 1 second. This table shows the reference value of the PI max from the residual volume For example, 40 to 49 age of men have a PI max value of 117.1 centimeter H2O, while the women have the PI max value of 92.9 centimeter H2O. This is the formula for the reference value for the male and female, and these are the formula for the lower limit of normal for the male and female. Clinical applicability of the PI max. It is helpful in diagnosis of inspiratory muscle weakness that occur in pulmonary, cardiac and neuromuscular disease. Differential diagnosis of dyspnea in obstructive lung disease of unknown origin. Assessing response to cardiopulmonary physiotherapy and rehabilitation in critically ill patient in assessing the possibility and success of weaning from the mechanical ventilation. General factors such as the older age, weak hand grip strength, malnutrition, poor health, low physical activity, short stature have all been associated with lower values. This is the graph. X-axis shows the muscle length and the y-axis shows the PI max. As you can see in this figure, during normal resting position, the muscle length is nearly normal and the PI max is 100% of its predicted value. As you lean forward, muscle length is decreased and the PI max reduce accordingly. Third one is the hyperinflation. In hyperinflation, there is a decrease in the muscle length which causes the reduced muscle inspiratory pressure in many patients with COPD. In simple terms, PI max decrease as the muscle length is decreased. Second one is the maximum expiratory pressures. It is also known as the MEP. It reflects the strength of the abdominal muscles and the other expiratory muscles. It is measured at the total lung capacity to record the maximum value. Total lung capacity means the maximum amount of air that can be held in lung after maximal inspirations. The clinical applicability of the maximum expiratory pressure is it helps in assessing the cough strength, expiratory muscle weakness correlate with the respiratory infection and the extubation failure. Same as the PI max procedure, for measuring this maneuver, patient is in sitting position with or without using of the nose clip. You have to instruct the patient to take a few tidal breaths through the mouthpiece or mask. Then you have to instruct the patient to take a maximal inspiration through the mouthpiece or mask to the total lung capacity and then blow out as hard as possible, and you have to maintain this expiratory effort for at least 1.5 seconds. And the largest positive pressure sustained for at least 1 second should be recorded. Allow the patient to rest for about 1 minute and then repeat this maneuver 5 times. You have to provide verbal and visual feedback after each maneuver. Variability among maximum value measurement to be less than 10 cm H2O. The difference should not be more than 10 cm H2O with each attempt. This figure shows the PE max. X-axis shows the time in second, while the y-axis shows the pressure. This is the peak pressure, that the maximum pressure that is achieved during the maximal expiratory effort, and this is the PE max, that the pressure that is sustained for at least 1 second. This is the reference value for the PE max that is obtained from the residual volume for the male and female. Third one is the sniff nasal inspiratory pressure. It is also called as the sniff nasal force. Same as the PI max, it indicates the inspiratory muscle strength. It is helpful for the patient with facial weakness who cannot maintain the tight seal around the mouthpiece for the maximal inspiratory pressure test. For the similar reason, it is also useful for the children over the 5 years of age. SNP is less reliable in individuals with occluded nostril or upper airway obstruction. since an adequate sniff maneuver can only be achieved if the contralateral nostril is not obstructed and allow the free passage of air. It is also not suitable for the patient with hyperinflation due to obstructive airway disease due to reduced transmission of pressure from the chest to the nose. Procedure: the maneuver can be performed in any body position, but the most common used position is the sitting position. For this, one nostril should be completely closed by the nose plug to prevent the pressure from leaking, and whereas the other nostril should be absolutely patent. Now you have to instruct the patient to sniff as strongly as possible through the contralateral unobstructed nostril and record the peak negative pressure in the obstructed nostril. Now allow the patient to rest for the 1 minute and repeat this maneuver until a maximal peak negative pressure is obtained. This may require up to 10 efforts. This is the normal value of sniff nasal inspiratory pressure and the maximal inspiratory pressure that is measured at the functional residual capacity in healthy adult. So the interpretation of the PI max, PE max and the SNP. Low PI max and SNP but normal PE max suggests that it has isolated inspiratory muscle weakness, usually diaphragmatic. A low PI max, SNP and PE max suggests that there is a generalized skeletal muscle weakness. For example, ALS, amyotrophic lateral sclerosis. Normal PI max and SNP but low PE max suggests isolated expiratory muscle weakness, although this is rare. PI max below the 1/3 of the normal predict the hypercapnic respiratory failure, means PaCO2 greater than 45 mmHg. A SNP that is 35% of the normal predict likely ventilatory failure in patient with ALS. A PE max less than 60 cm H2O predict the weak cough with difficulty in clearing secretions. A reduced PI max is associated with increased mortality. Fourth one is the peak cough flow. Peak cough flow estimates the effectiveness of mucus clearance and expiratory muscle function. It is performed with the subject in sitting position. The mouthpiece or oronasal mask that is connected to the pneumotachograph or the peak flow meter. You have to instruct the patient to maximally cough after taking complete inhalation, and the patient should perform this maneuver 3 to 6 times. Normal value for the healthy adult is 470 to 600 liter per minute, and the peak cough flow less than 160 liter per minute is associated with higher likelihood of extubation and weaning failure in neuromuscular disorder. Fifth one is the inspiratory mouth pressure. It is measured with the pressure sensor that is attached to the mouthpiece or the tracheal tube. Inspiratory mouth pressure also used in measurement of P0.1, which is the pressure that is generated in the first 100 millisecond of an inspiratory effort against the closed airway. The second part is the assessment of the respiratory muscle endurance. To assess the respiratory muscle endurance, different approaches are used. First one is the time trial, second one is the incremental load testing, and the third one is the constant load testing. Because performance during this test is influenced by breathing pattern, for example, breathing frequency, tidal volume and inspiratory flow rate, this parameter should be controlled. Resistive threshold loading test mostly apply to the inspiratory load, while the hypopnea test load both inspiratory and expiratory muscles. Hypopnea is the term for taking deeper breath than usual, which increase the volume of air in the lungs. First one is the time trial, where maximum ventilation with or without the additional resistance must be achieved within the given duration. For performing this maneuver, you have to instruct the patient to breathe in and out as rapidly and fully as possible for the 12 to 15 seconds. The total volume of air moved during this test can be expressed as liter per second or liter per minute. It reflects the status of the respiratory muscles, compliance of the thorax-lung complex, and the airway resistance. The validity of MVV depends on the maneuver. The frequency is equal to 90 breaths per minute and the average volume equal to 50% of the FVC. The formula for calculating the MVV is FEV1 into 40. This is the graph that shows the maximum voluntary ventilation x-axis shows the time, while the y-axis shows the volume in liter. This tracing shows the amount of maximum air that is inhale or exhale in the period of 12 seconds. Second one is the incremental load testing. In this test, there is an increment in load by increasing resistance or minute ventilation. It has two tests, resistive or threshold loading and the hypopnea. First one is the resistive or threshold loading. For this test, subject have to breathe against the resistance or threshold. The resistance load increase at a regular interval, minutes or number of breath. As the resistance increase, flow is tapered. For example, you can start with the 10% of baseline PMX until the task failure. The inspiratory muscle endurance can be defined as the pressure of the last completed step before the task failure. After the procedure, patient may complain of light headache or feeling low. Second one is the hypopnea. There is a stepwise increase in minute ventilation, 8% of MVV at every 3 minutes. It needs special equipment to assure the normocapnia. Normocapnia means patient have to maintain the normal carbon dioxide pressure, and the amount of time the patient is able to maintain this normal carbon dioxide pressure, that is recorded. According to the reference article, determination of normal values for an isocapnic hypopnea endurance test in healthy individuals aged 25 to 80 years old, the mean time limit was 21.8 plus or minus 5.9 minutes. Third one is the constant load testing. For performing this test, subject have to sustain this given resistance or hypopnea level to the task failure. In constant load testing, first one is the resistive or threshold loading. In this, subject asked to breathe against the maximum load until the task failure. The selected load should result in the time to task failure within the 5 to 10 minutes. After the post intervention, this duration increased to the 15 to 20 minutes. And the last is the hypopnea. During hypopnea testing, subject breathes at the constant ventilation, for example 40 to 70% of MVV, to achieve task failure within the 18 to 12 minutes. These all are the reference for this topic: Cynthia Norkin, Kapanji, Ellen Hilges and the Dona. Thank you.